Good afternoon. This is Andy Reese with Department on Disability Services. As always, I will start by sharing our current data. There we go. So as you can see, we've added one more person this week. As of this week, there have been 422 people who have tested positive for COVID-19. The one person that was added was in, now I'm not sure. So amongst the people who have tested positive, 6 have been in host home, 114 in intermediate care facilities, 1 in a mental health facility, 54 in natural homes, which is the one person that was added, now I remember, 2 in a nursing home, 4 in out-of-state placements, 37 in residential habilitation, and 204 in supported living. And so the sort of percentages by placement type, just among the major settings that we have, of the 114 people who've tested positive in ICFs, this represents about 38% of the total people in ICFs. And of those, 23 have died, but only 12 of those deaths have been confirmed as COVID-related, representing a 10.5% fatality rate amongst people in ICFs that has been attributed to COVID. The 54 people who have tested positive in their natural homes represent 5.8% of people we support in natural homes. And of those, 5 have died, and all 5 were confirmed as COVID, which represents 9.25%. In residential habilitation, 37 people who've tested positive represent 33.6% of the total. And of those, there have been 3 deaths, 2 of which were confirmed as COVID-related, representing 5.4%. In supported living, the 204 people who have tested positive represent 21.9% of the people in supported living. Of those 204, 21 have died, but only 15 of those have been confirmed as COVID-related deaths, representing 7.35%. Overall, the 422 people represent about 17.5% of the people supported by DDA who've contracted COVID. We have had 55 deaths of people who've had COVID. 36 of those have been confirmed or presumed COVID-related, representing 8.5%. And in March, there were 8 people in supported living and 4 in natural homes who tested positive for COVID. Of the people in March who tested positive, out of 12 people testing positive for COVID, 3 required inpatient care. There are currently no people in the hospital. Sadly, one of the people who required inpatient care died. We had 4 deaths in March. Of those 4 deaths, 1 is presumed to be COVID-related, a person who was in the hospital getting treatment for COVID and died within 2 weeks of being hospitalized. In terms of provider staff, to date, we've had reported 676 provider staff who've tested positive for COVID, 48 who work for more than one DDA provider agency, and 10 staff who have died from COVID. I don't have visual information to share, but I do have some fairly preliminary numbers, and I'll explain as I provide the numbers in terms of the people we support and the staff. In terms of vaccinations, people have received notice. We are starting our clinics next week for the second round of vaccination for a number of people. So there were 6 clinic days in the past month, and over the next 3 weeks, there will be 6 more where people will go essentially 4 weeks later on the same day at the same time to get their second shot. So if you went on that Tuesday in March, the first time that we had a clinic, then you'll go this coming Tuesday at the same time. And so the way that we are tracking vaccination rates amongst the people we support is that we have added a tab in MCIS. That tab allows a service coordinator or provider staff to enter current status regarding vaccination for a person. And so every person has a current status. With that said, not every person has data entered so far in MCIS. And I don't know if we were clear enough when we initially asked for the data to be entered. We do have, which I will share with you in just a moment, data confirming people who have received vaccines in MCIS, and we have some data reflecting people who have refused to get the vaccine. They're essentially, when you go into MCIS to complete the COVID vaccine tab, the first question is, has the person received the vaccine, yes or no? If it's no, it then goes on to various drop downs. Are they interested? Yes or no? If it's yes, some questions about their status in terms of being able to get the vaccine, or are there barriers to them getting it? If it's no, what are the reasons for the no? All of those people, which are some are in natural homes who are not receiving services from a provider, so that would be our service coordination staff, and others are supported by providers. Those folks who have no information entered, it's really important that we get that information so that we can begin to understand what is the reason that we're not yet at 90% of people vaccinated. So with that said, in intermediate care facilities, we're at 85% of people vaccinated. In residential habilitation, we're at 83%. In supported living, it's at 47%. And when I'm giving these numbers, this is people who have received a vaccination, either first or second. And in natural homes, it's 15%. I also know that when this same report was run a week ago, the number for ICF and ResHab, the percentage was at 32. So we didn't have that high number of people get vaccinated this week. I know that people are getting caught up now on entering the data, which is very helpful. Because as I say, we really need to understand exactly where we stand in terms of the percentages and what is the reason for those folks who have not received the vaccine to date, so that we can begin to direct whatever other supports may be necessary to help them. Including, one thing we'll be working on is resolving the question of providing vaccines on site to people who cannot travel to a location. And I hope to have more on that later. Amongst our provider staff, overall, of what we have reported in our system, which I don't think fully and accurately reflects the total, uh, the report is that about 25% of staff have received the vaccine. So amongst DSP staff, the total appears to be either the first or second. Now, the 25% reflects completely vaccinated. Amongst DSP staff reporting, 33% have received at least a first vaccine, first or second vaccine. Um, by placement type, we see the same kind of report in that total staff reported to have gotten either first or second dose who work at an ICF is at 49%. Total staff reported who have gotten first or second dose in a res hab is at 58%. In supported living, it's 30%. And so now I will say, as I also have it by provider, which I'm not going to share at this time, but when I look at that by provider, we are asking our quality resource specialists to follow up with providers to make sure that we have a full and accurate count. I would say on a positive side, these numbers are only going up. And, to the extent the numbers, there's a problem with the numbers. The problem is that we don't have full reporting yet. And so, an overall percentage in our congregate settings of over 80% is very good. We still want to figure out that last 15% to see what issues remain and how we can address them. And for, overall for staff, seeing 25% is a concern. But I don't believe that that's a full and accurate picture of the total people who've been vaccinated. But I just wanted to share the data that we have to date. We are, and as I said, the QRSs will be following up. We had sent something out to providers and asking them to enter the data into MCIS. And I think at the time, the time frame for entering it related to when the person gets the vaccine. So that was less than clear in terms of the importance of entering data for people who have not yet received a vaccine so that we begin to understand in terms of people we support, as well as, separately staff. That reporting is very different, but in terms of people we support, so that we can begin to understand what kinds of supports might be helpful to raise that percentage of people who have been vaccinated. For staff, we're just getting aggregate numbers from providers. We're not getting sort of, specific people or addresses, but we are getting the overall percentage from providers. And even with that, based on conversations with some providers, some of the numbers that I'm seeing and what we have reported look a little low. And so I want to make sure we have accurate numbers. But that is in terms of the data we have, as I say, that's the data we have to date. So now if there are any questions from people. So here's a question for our colleagues from DC Health. When do we anticipate that guidance will be updated to reflect recent CDC changes regarding quarantine and travel?
Hi, this is Nelson. So the travel guidance was recently updated and the quarantine guidance was also updated. So what specific changes are you referring to? Would be my follow-up question.
So if I could just, and I'm going to allow the person who asked the question to clarify, but I know that it was 2 or 3 weeks ago that Nelson did provide an update on those changes, and those were changes for the community regarding quarantine and for providers regarding quarantine and travel. But the sort of placement specific guidance for us has not been updated at this time. So if people are asking questions about any changes to our ICF policy, or it was ICF and CRF and supported living, those have not changed to date. So I do just want to mention a question came to just me, but I think it's an important question, which was, are we looking at for people who've been hospitalized, whether they've had a vaccine? And what I will say is that what was somewhat discouraging is that, and I think I had mentioned this last week or the week before when the one person was added to our list, is that we did have a person who had gotten a first dose of a vaccine, and a little more than 2 weeks later did become ill from COVID and did subsequently die. Part of what this points to is the importance for people who have appointments coming up in the next 3 weeks to get both doses, to remember that you're not fully covered by the vaccine until 2 weeks after the second dose. But the other thing is to also please remember that, as I just said, none of our guidance for our placements, for how we work with people, for all of the mitigation measures that we still need to be taking, none of that has changed. It is essential that people continue to use masks in the appropriate places, to use face shields, to maintain safe physical distance when possible, and to wash hands regularly. All of those things are still in place. The vaccine is one extra layer. It is an extra layer of protection for you. Do we have any data that we can share on the main reasons that people are not getting vaccinations? Not yet would be my answer to that question. We do have beginning data, but the way it's entered, I thought there were drop downs, but it looks to me like every single one is a different answer. And as I said before, we were not clear enough. So let me be even clearer, because I wasn't even clear when I said it before. We need to see every provider and service coordinator responsible for entering COVID data to enter the COVID status data within the next 2 weeks for each person for whom they're responsible for entering that data. Not just entering the data when a person gets a vaccine, because you will see as you go in, if you check no, then we get the drop downs to provide us the answers to questions that were just asked here, which is, if it is no, the person hasn't been vaccinated, are they interested? are they registered? You know, what are the barriers? Or no, they're not interested. What are the reasons? What are those barriers? So it is really essential that provider staff and service coordination staff responsible for entering COVID status data on the COVID tab do so in the next 2 weeks so that we have good data so that we can see even, you know, the 83% in residential habilitation, um, you know, that represents 17 people who have not gotten a vaccination. We need to understand what those 17, what's the reason that those 17 people haven't had a vaccine. And it could be that they just had COVID and it's not time yet. It could be that at the time it was scheduled, they were sick and a new one needs to be scheduled. It could be that they were opposed or that a healthcare decision maker was opposed. But we need to understand what those reasons are and make sure that we're following up. So, as I said, we need to make sure, and QRSs will be reaching out as well as service coordination supervisors to ensure that over the next 2 weeks, an answer is entered in terms of COVID status for every person. And then we can have more thorough and complete responses to that really important question. Being that there are so many different COVID-related reportings that are being requested of the providers, can we be sent an email with all forms that are required to be sent and to whom it needs to be sent to ensure that we're receiving the most accurate data? Um, yes, I'll ask Kirk to send something out to everyone just to summarize, here's what we need from you. And as I said, I do expect that the QRS will be reaching out to their contact at each agency to say, here's the different information we need from you, and making sure that we have accurate current data. Thanks. Any ideas on how the additional funding that will be coming through the Fmap bump in the latest COVID relief bill will be spent? So the most recent COVID relief bill included a 10% increase in the federal match for waiver programs. CMS had a listening session with uh, a number of stakeholders, including us and NASDs and all, you know, other state agency DD providers, so that we could provide input on what we would like to see. There has been no guidance on what can be included. Some of the things that states are looking to do are the kinds of measures that we have been doing with the initial Fmap enhancement that began in fiscal year 20. We explicitly, directly expressed our concern that about whether there could be some allowance for additional retainer payments for day services. We have also been taking a look at, there was some guidance put out a few years back from the Kaiser Family Foundation that summarized when a similar opportunity was available for a number of states, the different kinds of things that states did. And certainly I think that some of what we will be looking at is how we might be able to use that investment to give a little more of a, I don't want to say jump start because we're a little later in the process, I wish, than to talk about jump starting, but a lot of our technology efforts, because the challenge with this Fmap bump is you have funds to spend that you want to make sure that you are not creating an ongoing obligation because those funds are available for 1 year only. Oh. S- And one thing, I don't want to put someone on the spot, but I am about to. Um, DHCF has forwarded to the Centers for Medicare and Medicaid Services our requested revisions to our Appendix K. And so I'm wondering if Chanel's supervisor is available to review those with us, keeping in mind that these are our requested changes to the Appendix K. So
Hi, everyone. It's Crystal, Chanel supervisor. Um,
I didn't want to call you out completely.
That is okay. Happy to share. As Director Reese mentioned, these are proposed changes. We have not received the approved Appendix K from CMS. So I'll just give an overview, just reviewing my notes right now. So in terms of services, we allow remote service delivery for DAHAP, IDS, employment readiness, OT, speech and language, creative art therapies, physical therapy. With IDS, we can now proposing to exceed the limit of 5 days, and it may be provided up to 7 days per week, but not exceed 6 hours per day. In terms of modifying the service scope for assistive technology, we requested to expand providers to include general retailers, expand provider certification requirements to include certified enabling technology specialists in accredited technology. In regards to settings, temporarily allow for DAHAP, IDS, employment readiness services to be delivered in alternative settings, and as well as in the participant's residential setting, i.e. a natural home. In regards to staff ratios, in IDS, ratios may increase but not exceed 1 to 3. And DAHAP may increase but not exceed 1 to 6. And small group, it may increase but not to exceed 1 to 6. Companion services may be rendered by the person's relative, legal guardian, or person who is otherwise legally responsible for the person. In regards to trainings or qualifications, you are able to complete the online CPR and first aid trainings. So this will be considered and is sufficient to satisfy the annual certification requirement for DSPs. So previously, we requested if there were any online trainings for you to then have an in-person training. But we're proposing for the online to be satisfactory. There's a temporary request to increase payment rates. And this will be a one-time supplemental payment available to eligible providers employing DSPs. And the purpose of it is to ensure that DSPs continue to receive competitive wages during a public health emergency. And this will be for services in ResHab, regular supported living, with or without transportation, as well as companion services. And last, we are proposing a one-time payment of $400 per person supported to assist in the purchase of PPE during the public health emergency.
If I could ask 2 clarifying questions. One is on the IDS limit, while it can be 7 days a week, and you said the number of hours per day, but also the number of hours per week cannot be more than they were before, right?
It's 30 hours per week.
Right.
Right.
And the other was when services are being provided remotely in a home, there can be concurrent billing for day services and the residential services that are needed to support the person to participate in the day service, correct?
Correct.
Okay, so
And that's what we are proposing, everyone.
I was just going to say that's our request.
Absolutely.
So we will
Hasn't
keep
been
you posted.
approved. Yep.
And the one-time only payments, so people are aware that we've been working, or DHCF particularly has been working with our provider coalition on developing a mechanism for providing a bonus that would begin to address some of the DSP wage issue. And so that's what that amount is for. So following up on the question about guidance, is DC Health working to update guidance for people supported by DDS who have been vaccinated? I'm going to ask Nelson to address that, but I also, before Nelson addresses it, I want to say we have gotten some questions from people about if we have a day program and all of our staff is vaccinated and everyone who comes is vaccinated, can we dispense with masks? No. So nothing in that guidance has changed because there are vaccinations. I do know on a personal level, if I now go to visit someone who lives in a different household and I've been vaccinated and they've been vaccinated, we don't need to wear masks in that small gathering. That's the change I'm aware of. So from there, if Nelson could expand further.
What was the question? Can you just repeat the question one more time?
Is DC Health working to update guidance for people supported by DDS who have been vaccinated?
So I think, like I said last week, we're constantly updating guidance as it gets released by the CDC and evaluating the appropriateness of it in our setting because it's not the same for everywhere. I think last week I quoted the mayor when she said that the relaxing of restrictions is not cookie cutter for everybody across the country. It's going to be different based on the different areas and settings and the needs of specific populations. And so we're continuing to update as things come out. If there's a specific question that you have, like a specific scenario or something like that that I can answer, I'm happy to do that. But otherwise, we're continuing to update, and you can always go to coronavirus.dc.gov under healthcare guidance and look at the most recent updates. I also put in the chat a link to the most recent travel update guidance, as well as the most recent quarantine updated guidance.
So the quarantine guidance doesn't change, that doesn't change the quarantine requirements, or does it, for people supported by DDA in their placements?
So,
and I remember you went over the guidance, but I don't remember the answer to that question. Sorry.
Sure. Well, for quarantine, 14 days is always the safest option after somebody's been exposed. There is some public guidance regarding exposure and the opportunities to reduce quarantine after exposure. But if you remember when we talked about before, things, and we try things in a public setting before we do in the higher risk settings, such as, long-term care and assisted living and high risk populations. And so nothing has changed regarding the quarantine recommendations for those populations that you mentioned. But it is outlined in pretty good detail in the quarantine guidance. And if there's any more specific questions, I'm happy to ask them or to answer them.
Thank you. So from a provider, they attempted to complete a reimbursement for remote support services, and they received a denial saying procedure, place of service conflict, authorization, modifier conflict. I know this is a new process, however, are we the only one having these issues, and is there someone who can provide support? And either Winslow or Hakima, if she's here, perhaps can answer that. It's generally DHCF, but maybe one of you know exactly who. Hmm.
Andy, I'm not sure if they're actually on the call. This is Jared. I've taken a note of this and will follow up with DHCF. I have the complete question and I have the name of the person who asked. And then we can provide an update to the entire group if it satisfies the entire group.
I've just made Winslow a panelist, so if he wants to speak, he can now unmute himself.
Thank you so much, Kirk. I was just looking over the question. So the service was provided remotely and the provider's unable to bill. Oh, they attempted to bill and then it was denied because
Correct. So who would help them with that? And it says it's in-home remote.
well, I would want to know whether the in-home remote was approved by the team in the ISP, because if you recall, when we had issues about providing remote services, you can't provide remote services without it being formally discussed with the team and the person agreed upon. So I guess I would need to know more. But my first question would be, if the service was authorized and then it was rejected upon billing, that it's likely a DHCF issue. I also would like to know when it occurred, because if it was, it's my understanding that once we've started doing the EVV, there are ways that remote services can be billed, but there are specific codes that have to be used to bill remote services where EVV is required. So if the service was,
Where should that question begin? Is that a question for service coordination, for
it should
waiver?
start, in my opinion, it should start with waiver, because they are more familiar with the actual, well, there has been a distributed list of codes used for services that are allowed to be provided remotely with regard to billing. So it may be related to the EVV. So I will, as George State, reach out to Pam Harmon, but I also think that it's good information for the entire group, as was stated, and we can share the answer. For some reason, I'm not seeing the question in the chat.
Oh, because it was to the panelists and you weren't yet a panelist.
Thanks. Okay, if you could copy paste it and send it to me, we'll follow up on it.
Okay. Is there a place in MCIS to record data regarding agency staff having been vaccinated? No. And so, as I said before, I'll ask Kirk right after this meeting to provide a summary of data that providers need to be submitting, COVID-related data, and our quality resource specialists, I'm pretty sure, are reaching out each week to update this COVID vaccine spreadsheet. We don't get individual level data regarding staff who've been vaccinated, but we do ask for the numbers by placement type so that we know overall where providers stand, but we're not asking providers to share the individual staff person's name and that kind of health information. We are asking the providers to gather the information and provide us with the aggregate data. Sorry, someone said they know that you're talking about home and community-based services funding, but what does Fmap stand for? See, I was afraid you'd ask that. It is the federal match, and maybe someone can say what all four letters stand for, but that is the federal match.
Federal Medicaid assistance percentage.
Thank you. So it is the for the waiver, it's the percent that the federal government pays for our costs for waiver services. That is typically 70%, but during the public health emergency, it has been increased now for the second time. The first time it was increased 6.2%. During the time of the public health emergency. So for each quarter in which we continue to be in a public health emergency, there's the additional 6.2%. And now it has been increased an additional 10%. One thing I will say, just to provide some context, in FY20, and we will be doing a budget forum in a few weeks, right before our budget hearing. In FY20, our waiver expenditures increased 15%. So we did get some additional funds from the federal government to cover the additional costs. Oh, I see that people have answered that question. Thank you. Just to be clear, the proposed increase of rate for, I don't know what DSOs is, during the state of emergency is only for those who work in residential settings. However, there's also a proposal that enables day programs to render services. Given that the risk is pretty much equal across settings, is there a plan to pay DSPs equally regardless of setting? So just to be clear, in our Appendix K, our rates were increased across the board in all setting types. Crystal could correct me if I'm wrong, but I'm pretty certain that's true. That would allow providers sufficient funds to provide an increase in DSP wages. There is also the incentive payment that allows for an additional increase for this year for DSP wages. And that is separate. That relates to, there were funds in DHCF's budget in FY21. It was $1.4 million that would allow to cover some of the cost of increasing wages related to the DSP Wage Act. And so, as I said, there were meetings over months, I would say, to discuss how to go about implementing that. Essentially, it's that bonus. What is the status on the provision of companion services by a family member? Has the Appendix K addressed this concern? Answering the second question first, we addressed this concern in our proposed Appendix K. The Appendix K is currently with the Centers for Medicare and Medicaid Services for approval, but it has not yet been approved. So once that is approved, we will let everyone know, and we'll send out communication to all providers about that. Someone is saying we're experiencing a challenge receiving authorizations for remote services so that they can properly bill. Does the ISP need to be amended in order to receive the authorization with the correct modifiers?
The answer to that question is yes. you do need to have the service authorization with the correct modifier codes to be able to bill.
So this says, given this new CDC guidance, it seems to me it's time for DC Health to revisit the quarantine guidance for fully vaccinated people supported by DDS, starting with supported living. And I think, I mean, I can allow Nelson to respond, but DC Health reviews updated CDC guidance regularly and updates all the respective guidance based on that guidance and the circumstances in the district. But Nelson, did you have anything to add to that? I don't know which updated.
I don't have anything to add. You know, we are, you know, like I said, we're constantly reevaluating the recommendations, and there's a lot of moving parts, is all I can say. And so when it becomes available, we will update you on the updated guidance. But for now, things are the way that they are, the way they stand. So please refer to the current guidance. And when it updates, we will let you know.
Oh, and I do see, so they have a meeting where they discuss updated guidance. I see that this guidance was issued by the CDC today. So I expect that since I've been in meetings with Nelson at 9 o'clock this morning and now, that I expect they haven't had a chance yet to have a meeting where they've discussed these changes that were posted by the CDC today.
So you actually, I am aware that there were some changes that were posted today, and we're in the process of reviewing them.
Great. Thank you.
Thanks. Thank you, though.
So, if a team agrees that the day program can have all 3 or 4 of their people in day hab attend a virtual program with a staff that used to have them on their caseload pre-pandemic, given the fact that the day program can provide a schedule, supply the material for daily activities, complete documentation, is this something that can be discussed to implement with compensation to the day program? I mean, it sounds like it's something that is included in, is this included in the updated Appendix K, Crystal, or is this already allowed? I think it's in the revised Appendix K, keeping in mind those 3 or 4 people who are participating previously would have attended a day program for 6 hours. And I don't expect that people would do 6 hours remote day services in a day. 1 hour, perhaps, 1 hour in the morning, an hour in the afternoon. As someone who sits in front of a computer participating in meetings for a number of hours each day, I can say that the amount of time that a person can actively engage in this is limited, but I would like to hear from Winslow on this.
Yeah, the idea of being on a computer for extended periods of time doesn't seem like optimal way for people to spend their time. And I guess, I would defer to the individuals, teams, and people who know them best and be very um, considerate of what that really means for a person to be sitting and engaging uh, with others via the computer. And I know that there are probably some very creative and thoughtful programming that have been developed. And, you know, I've seen some, but at the same time, I think it would be the teams uh, that have to really be thoughtful about that. And I've spoken to some of the providers who are providing services, and they're very mindful that they are not anywhere near the number of hours service being provided remotely as it was when people were face to face. It's not realistic, and I think those who are thoughtful about running their businesses and their programs know that to be true. But we don't have a rule on how many. I think we addressed it in the K. Generally, I have to look at that, but we didn't specify specifically the number of hours. So let me pull up that real quick.
If a DSP was exposed via a family member and eventually tested negative but quarantined, can the agency bill and pay the quarantine rate and pay the staff accordingly? No. So just to clarify, the quarantine rate would be if the DSP came to work and the person they're supporting is quarantining because they have or are suspected to have COVID. If the DSP was exposed to COVID in their own personal life, they should stay at home and quarantine. Now, the CARES Act did provide funding for our provider agencies so that they can pay the DSP to be at home during a period of time they need to quarantine. I think it's limited to 2 weeks for a person in the year. So there are some challenges with that. But that person shouldn't be coming to work. And so, the risk there, the reason for the quarantine rate is based on the risk to the people coming to work. In this instance, the DSP should be staying at home so as to not present a risk to the other people working there or the people living in the home. I do see that it is 1 o'clock. I hope everyone has a very nice weekend, and we will talk again in a week. Thank you very much.